one of the things that we really need to realize is there is a difference between what happens in rural India and what happens in urban India. The reality is in rural India, patients tend to come and seek medical help at a much later time. So by the time we are actually getting to see a patient and by the time we're examining patients, it's already been 10 or 12 days since they've had the infection. Initially, we had treated, we had used Remdesivir, and there's a few problems in rural areas with Remdesivir itself, especially last year. If you look at the cost, an average rural person cannot really afford it. And one of the things that we were looking at is what is a safe and effective way to treat COVID victims. We all know that about 80 to 85% of COVID patients basically can get better with very little medical involvement. It is really that 15% that tends to actually need hospitalization.
Yeah.
And I think what happened in India, and we as Indians always have fads. And for example, an example of this is, let's just take a look back and think about March or April of last year. And one of the things, our first fad in this country was N95 masks. Everybody in this country was running around paying exorbitant amounts of money just to get these N95 masks. And then soon we realized that cloth mask works fine, surgical disposable masks work. Now we also realize that double masking works just almost as well as N95 masks. So this was our first fad last year. Our next fad became hydroxychloroquine a few months later. Then there was a shortage. Once again, everybody was prescribing that, whether patients needed it or not. And then the third craze, of course, is these two drugs, both remdesivir as well as toxizumab. Okay. Now, I'm sure I'm not going to go into this debate whether it helps or doesn't help. But WHO had said that they did not see much of a difference, and they didn't see the efficacy of remdesivir in most patients. So we kind of, from last June, July itself, we started shying away from that drug and decided not to use it. And in spite of that, I mean, I think we did a kind of right approach, in the sense we looked at each patient on a day-by-day basis and made mostly symptomatic calls as to what the treatment plan was. We do use, last year, we were using a lot of methylprednisolone as a steroid, but even then, we were waiting until they were actually in a cytokine storm. So where their immune system was getting overloaded, we did try some antivirals like Fabiflu and things like that, just to see if they would work on the viral load. Honestly, we did not see any difference between giving it or not giving it. And then once again, it's a cost factor. So we were also looking at and trying to balance cost factors. And one thing we realized is that in treatment, and this is even common sense, for any illness, there's windows of when you can introduce a drug and when you should be using those drugs and when you shouldn't. And I think what has happened is, and why we're seeing a shortage of remdesivir in India, is the overuse. I think in many places it is being used unnecessarily, and actually that is not good clinically. I mean, these drugs can cause more harm than good. And it's the same thing with steroids. There is a timing and there is a dosage, and I mean, and does everybody need it? No, not really. We should be looking at what do we do for this 15%. Unfortunately, right now, nowhere in the world is there sort of a single drug therapy that is proven and works or anything like that. But through trial and error, I mean, to give you an example, up until April 1st, we had treated over 3,700 patients and we had had only 13 deaths. And these were pretty much quite severe patients. And so, even without using very fancy drugs and some basic drugs, we are having still a good success rate. Our death rate is now hovering, it's a little bit higher than last year. It's still hovering around 1%, but that's still well below the the national average. We have the skill set. We need to use this for the good of the people. Okay, we have made money before, we can go to making money afterwards. But this is a national pandemic, it's a crisis, and it's absolutely unethical. And I feel that these people should not, their licenses should be removed. There should be audits done. Something has to take place from the government. This is not the time for us to prey on the weak and prey on COVID victims. It is just, there's no words to describe how angry I am at this whole situation with these physicians trying to rip people off. It's nonsense. And it's the whole circle. And it's once again preying on the sort of oppression of people who don't have the knowledge, and especially in rural India. Another thing that has to be done is this whole craze about this HRCT. Less than 10% of people need an HRCT done. Okay, it is a very dangerous thing. You're exposing young people for no need to huge amounts of radiation. And then 10, 15, 20 years down the road, we're going to see the devastation that this HRCT is going to do.